Hello, and welcome to another edition of Hadassah On Call podcast. Today, we're talking with Dr. Gal Goldstein, Director of the Department of Pediatric Hemato-Oncology at Hadassah Medical Center. Dr. Gal Goldstein is an expert in blood diseases and cancer, and his department works with patients suffering from both diseases. He says blood cancer is the most common pediatric cancer. Many parents fear that their children could develop cancer, and maybe they wouldn't know it. Dr. Gal Goldstein will tell us when to get worried. He'll also answer questions like whether cancer is genetic, what the long-term impact of cancer is on children, and how cancer doctors make it through the day. Welcome, Dr. Goldstein. So I'm very fortunate to have with us today Dr. Gal Goldstein, head of the Dinah and Fala Weinstock Pediatric Hemato-Oncology Department at Hadassah Hospital Ein Kerem. Now, Hemato-Oncology, that's an unwieldy name for a department. What does that mean, and how did you end up in charge of it?
It's a combination of two fields. Hematology, which is the field of blood diseases, not benign diseases like anemia, thrombocytopenia, and other problems in the blood, and oncology. Since the most prevalent cancer in children is a blood cancer, leukemia, it was merged as two fields throughout the world and also in Israel. So we are experts also in blood diseases and which are benign diseases without any relation to cancer, and oncology. We treat all types of cancer in children. It's a little bit different than in adults. In adults, they have the oncology department and the hematology department when they treat the blood cancer over there. So we're a combination, and it's a very, very diverse and heterogenic field, I think.
So give me a little background on yourself. How did you end up at Hadassah?
I went to the medical school at Tel Aviv. I live in the Tel Aviv area. And then I had my residency in pediatric in Asaf HaRofeh, which is also in Tel Aviv vicinity. And then I went to Tel HaShomer to do my fellowship in hemato-oncology, pediatric hemato-oncology. And for 15 years I was in Tel HaShomer, and then in 2017 I came to Hadassah to direct the pediatric hemato-oncology department.
Are you enjoying being in Jerusalem?
I like Jerusalem. It's a completely different atmosphere, completely different place from Tel Aviv. Everyone said that Tel Aviv and Jerusalem are different states. I think it's amazing. It's a mixture of cultures that you don't see in other places in Israel, and it's different. Even people told me that Arab from the north are very different from the Arab in Jerusalem. Culturally, people who are either secular or Jewish Orthodox are different in Jerusalem, and even in Jerusalem, the vast heterogeneity of cultures is amazing each time, and I'm still learning.
Amazing. So, Dr. Goldstein, I'm actually a mother of 7 children, a blended family of 7 children, and my children range in age from 6 all the way to 19. And one of the biggest fears that I have is that, one of my children could actually develop cancer themselves. So your child, he says he has pains in his knees, having stomach aches, something's bothering him. Do you just assume it's average, childhood pain, or when do you start to worry? What are the signs and symptoms that your child is suffering from cancer?
I've been asked this question maybe hundreds of times, and I don't have an answer. No one has an answer. They say a pediatrician that works in the community, like in Kupat Cholim in Israel, or I don't know, in an office in the States, he would see only 2 patients with cancer throughout his professional life, throughout his career. So it gives you a sense of, it's so rare. I see a lot of them. Every day I see many of them, and people are so afraid of it justly. But it's very rare, and it's very difficult for the families and for pediatricians to pick the right moment to say this might be cancer. We have algorithm in medicine. You have red flags, for example. Most of children have abdominal pain, knee pain. Sometimes they look pale. Sometimes they have fever for a week or so. All these signs could be signs of cancer, but usually they're not. So it's very, very delicate job. I will tell you, from my perspective, maybe this is a good example. But when I was maybe 4 or 5 years into my fellowship in Tel Aviv, I was an experienced pediatrician in hemato-oncology. I knew that it's rare, but still, when my daughter, she was, I think, 8 years old, when she came to me and said, "Hey, father, I have this blue spots on my knee," and every doctor knows that blue spots on the knee might be a problem with the platelets, with the coagulation system, which might be in very, very rare cases leukemia. But most children that have blue spots on the knee, maybe they had a bump from the table or something like that. And I remember me doing my jogging in the evening and thinking, where should I treat her for leukemia? Because as parents, we are completely illogical. You cannot escape from the fear. But again, if I'm trying to be rational, getting out of my job as my role as a parent and being a professional oncologist, it's so rare. Only when signs, I think, are not regular, taking too much time to go away, and maybe when the pain is so severe, and then you have to worry, I think. But if you get a good pediatrician, usually he will do the work. He will do to find the red flags and not to worry about too much.
Wow. Did you take your daughter in to get her checked for leukemia?
Yeah. We did a blood test and it was okay. And I was thinking, why did I jog and thinking about this leukemia? Because I'm a parent also. And you cannot escape from it, I think.
100%. So, it's interesting because I would think also that as a parent and an oncologist working with children, that it must be extremely emotional to be in the department. One of the hardest places I would think for a doctor to work. Can you talk a little bit about that and how you detach or attach to your patients and their families?
Yeah, I think about it all the time, maybe every day. I look at my team. I think the thing that are going through every day, whether they are nurses, doctors, physiotherapists, psychotherapists, even the office crew. It's very difficult. We go to work as any other people who go to the factory or to their offices, but we deal with the tremendous, where people are undergoing a huge turmoil, I think. And it's very hard. It's very easy to be empathic, I think. And if people are not empathic and not have compassion for the children and the families, they will not be able to survive this very hard place to work in. But on the other hand, you have to draw a line when the agony and the pain and the sorrow that is there, you cannot penetrate your personal life. We had people who could not do it, who left. Very few of them. But some people are finding it very hard to distinguish between the private life and the professional life. But I think if you don't have this, I think everyone has it. Everyone, even if you work everyone has compassion for people because we're people. But when you work in such a place, and if you come there, you'll see, I think it takes out of you from people the good thing, the good qualities, the need to be compassionate, the need to, for example, we have Arabs and Jews, and we have ultra-Orthodox and Orthodox. We have secular, and this is a bubble. A hospital is a bubble. Pediatric department is a bubble, but I think this is a more extreme bubble. The oncology we almost don't have any conflicts, not between nurses and doctors, not between doctors and families. They all live in such a harmony because the amount of, I think the word is amount, the amount of compassionate, the amount of humanity is amazing in that place. You need to work with it every day. You don't just, today it's going to be a special day. Every day they come there, no matter what their role is. Again, could be only a secretary. And it's very easy to be human there.
It's incredible. There must be a lot of differences between pediatric and adult oncology in that way. I mean, maybe you mentioned it a little bit at the beginning, but maybe talk a little bit about that from a practical perspective.
The first issue is the amount. There's 50 to 60 times more cancer in adults than in children. For example, in Israel, we have 30,000 of new cases of cancer each year, and in children, only 500. So this, as I said before, it's very not an easy task to pick the patients from the community to say, hey, he may have cancer, he or she may have cancer. This is one point. The other point that the cancers in children are very different from the ones in adults, almost completely. And there's almost no overlapping. Most of the cancer, or many of the cancer in adults, have some relation to environment. For example, smoking, food, nutrition, sun. Some say the cellular phone, but no one really is sure. It's type of cancer or hormones, even the internal environment. There is a relation, for example, between breast cancer and the amount of children that a woman had during her life. In children, it's not like that. We don't find almost any relation to environment.
Do you mean that they just develop cancer and we don't know why?
Exactly. We still don't know why. Maybe if we did this podcast 20 years from now, we would have known, we would have more information, because we think it's genetics. We think there's at some point of development, there's maybe a mutation that is being caused by them. We don't know why. Mutations are consistently happening in our body. And we don't know why, but at some point there's a mutation that is causing cancer. Until now, we can identify about 10% of the cases that we find mutations. Hey, this is the mutation that caused the cancer. 90% we don't find. I think, but we're in the middle of, we're during a revolution, a genetic revolution, and we're doing more and more genetic tests for the children who have cancer. And we will find out, I think, more genes during the next few years. When another point is, when I'm saying genetic, it doesn't say that it was inherited. Usually the genes got the mutation, or the mutation happened in the cells after the conception, they didn't get it from their parents. So mostly.
I'm going to actually ask you about that with genetics. I mean, let's say, God forbid, a mother has breast cancer. Is that indicative that a child will have a cancer as well?
We have algorithm. We have a certain tables that they're saying if we have this and that amount of cancer in the family, mainly cancer in young people, meaning young people before the age of 40, 45. This is cancer in young
45
people.
Is no longer considered young when it comes to cancer?
Yeah, we don't, if the grandmothers or the grandfathers had cancer, we usually don't take it as a risk factor for the children to have what we call a cancer predisposition syndrome. But if they have a typical story, a familiar story that many people had cancer during the 40, until they were 40 or 45, usually we regard it as a suspected cancer predisposition. And today the genetic technique that's all developed, so we just send the genetic test and we find it. When we're speaking about cancer predisposition, it's very interesting because we at Hadassah, we have a research that we started about a year ago, that we're using artificial intelligence, AI, computers, to find, we are collaborating with our adult oncologist colleagues, Dr. Shai Rosenberg from the Hadassah Oncology Department, and he and our Dr. Hadassah Cohen from our department, they're doing joint research. They're taking blood from all the people, all the children who have cancer, who have cancer, who develop cancer, and we're doing a genetic test, and we're trying to use computers, the AI, what we call it, to find the mutation that until now are not known to the science. And hopefully, when this research will be over, we will have more information about this genetic cancer predisposition, which is, I think, it will grow and grow again. And at Hadassah, we have a very, very good infrastructure for this scientific project.
Incredible. And I mean, we're talking now about diagnosis, but also what about treatments? There's many more treatments out there today. Can you talk a little bit about that and what Hadassah is doing to treat patients, and also in general, what some of the new treatments are looking like?
First of all, I think we should contribute to the history, to the people who were pioneers in pediatric oncology. Because not many people know that in the 60s, about 80% of the children died from cancer. I mean, 1960?
It's not so long ago.
Yeah, not so long ago. It was only 20 to 30% of the children recovered from cancer. And then within 15 to 20 years, I mean, not 2020, 1980, 1985, about 85% of the children recovered, or around 80% in the 80s. Meaning the huge escalation, the huge growth of in survival rate happened from the 60s to the 80s.
Is that from chemotherapy?
This is from chemotherapy. The first revolution, we are in the second or the third revolution now, but the first revolution was the chemotherapy. The invention of chemotherapy, or the knowing how to use it in the correct way, and another thing, and to give them the correct supportive care, because if you give chemotherapy in departments who are not capable of treating infections, for example, or other things that happen when you give chemotherapy to children, and the level of the intensity of the protocols in pediatric oncology is much harder than in adults. It's one of the reasons we think we look at children as little cute and delicate creatures, but they're stronger than us. When I give chemotherapy to a girl at Hadassah, for example, a girl with leukemia, she's 2 years old, and I give the same regimen to a 15-year-old guy who is very muscular and is an adolescent, she's taking it better than him, because our body is having his, let's say, he's getting old even during our childhood. So children take the regimen, the intensive regimens, quite well, and we give them very hard chemotherapy regimens because the odds of recovering are very high, and because they can take it, and it's proved. This is what makes them. For example, leukemia, the most prevalent one, ALL, acute lymphoblastic leukemia. This is the most prevalent cancer in children. In the 60s, no one recovered. In the 80s, 80%, and growing from 80% to hopefully 100%. I don't know when, but today we're reaching 90% recovering rates in ALL, in leukemia. This is the second and the third revolutions, I think. This is the molecular, the targeted molecular drugs that are getting into pediatric oncology these days.
Is that like precision medicine?
The precision medicine. It is built on the pillars of the genetic revolution, except doing what we call germline, the genetic test in the blood. We do genetic test in the tumor itself. The genes in the tumor are different from the genes in the in the other parts of the body. And we're doing at Hadassah to all the children who has, no matter what type of cancer, we're doing sometimes we do few genetic tests. We're still not in a place that we use it as much as we would like. We still use a lot of chemotherapy because it's very hard these days, but I think progress will come. It's very hard these days to find what we call actionable mutations, meaning, hey, this is the medication you need for this cancer. Usually we have stories that there were very big success without giving chemotherapy to children. Most children still, even in 2022, still get chemotherapy, most of them.
And what about immunotherapy? Isn't that the newest phenomenon?
Another thing is immunotherapy. In the last 10 to 15 years, there was a very big revolution. Even Nobel Prizes were given for people who developed these techniques. Using the immune system to fight the cancer in many ways. We also use it in pediatric oncology. Maybe a little bit like precision medicine. I think the adult oncologists still have more cases that they can use the immunotherapy. We are looking at our adult patient colleagues. We look at them maybe a little bit envy that they can give so much immunotherapy. We try to give immunotherapy to children. In certain cases, we use it in leukemia, for example, or in other tumors that we call neuroblastoma, which are mostly in the abdomen. We use it. And hopefully with research, and many of the researchers, the studies are doing it at Hadassah, we will be able to use more immunotherapy in children. For example, bone marrow transplantation is a type of it's also a type of immunotherapy. Some children do need bone marrow transplantation, many leukemia patients, and some patients who are not cancer patients, they have genetic diseases that we should replace the ill bone marrow with a healthy one from a donor.
And Hadassah was a pioneer in bone marrow transplantation.
Hadassah was a pioneer in Israel, and also when you look at it globally, Professor Shimon Slavin established the first bone marrow transplantation department in Israel at Hadassah, and he was a pioneer. He was also developing novel techniques of bone marrow transplantation. And these days, Professor Polina Stepansky is heading this bone marrow transplantation department, and we are very proud of this department.
And let me ask you this. You brought up before how there are Arabs and Jews inside the ward, religious, non-religious. It's an incredibly diverse ward. But there's also a lot of languages, when you come in the ward that you can hear people coming from abroad to get treated at Hadassah. Talk a little bit about that. Why would someone come to Israel to get treated?
The resources, I think, they know that they get a very, very high standard, cutting edge treatment at Hadassah. Not in all the countries throughout the world they have the opportunity to have this type of treatment. I don't think there is a treatment that is given today at the pediatric oncology field that we don't give. We are connected to the best centers in the world. We are connected, of course, to the literature, and we know what's happening. And we didn't ever had any problem in getting any medication. And also we're very experienced in most prevalent cancer in children oncology, but we are also very capable in treating the most scarce types of cancer. For example, we're doing at Hadassah a trial for treating neuroblastoma, which is one of the prevalent cancer in childhood. But when in very, very hard cases, when the disease is metastatic and there's no way of treating children, we're doing a trial of giving radioisotope, a nuclear substance throughout the veins, and special molecular way it will traffic its way to the cancer cells and kill them. And this is a clinical trial that we're doing at Hadassah. And many other examples.
Can you talk maybe a little bit about the research that you're doing, which is seeking to ensure compassionate care for children?
Yeah. For example, one of the problems that I was saying very good things about the high rates of overall survival in leukemia, in ALL, in acute lymphoblastic leukemia. But one of the problems, for example, that we anesthetize children who have leukemia about 11 to 13 times in the 9 months that they have it, the intensive part of their treatment. So anesthesia is, we can do it. There are professional anesthesiologists, but if we can prevent it, we'll be happy to prevent it. We do it because when you do a bone marrow puncture to see if there's remnants of leukemia in the bone marrow, it's painful, so you have to anesthetize them. So one of our research is using blood samples to see if the short fragments of DNA from the leukemia cells in the blood. We're doing it together with the scientists at Hebrew University, which is next door to Hadassah. This is one of our projects. Hopefully in the next 1 or 2 years, we will have preliminary results for it.
What would that do? Meaning you could take a blood test instead of having to anesthetize?
We may be able to do less bone marrow aspiration and rely on the blood test. This is one of the main places that oncology is going today. We call it liquid biopsies. If you maybe in the next, few years, we will be able to not to need to do biopsies at all. If a person, whether he or she is an adult or a child, would have, God forbid, a mass somewhere in the body, today we have to puncture it under anesthesia. Maybe in the next few years, we will be able to locate fragments of DNA that coming from the dead cells of the tumor and find it in the blood, doing a liquid biopsy.
And you're thinking even in the next 5 years, though, we could see something?
I don't know if 5 years, but I don't know. In some, for example, in colon cancer in adults, they already following the people with the blood tests to see if there are metastases, if there are tiny focuses of cancer that it's still there. In children throughout the world, there's a very big research in that field. We're also trying, together with scientists in the Hebrew University, we're trying to find clues for the tumor cells in the blood. And it's not easy. It's not that easy because there's a lot of what we call white noise in the blood, many types of cells, many types of DNAs, but each time there's another step for doing liquid biopsies in cancer children.
Amazing. We always used to talk about going into remission rather than a cure for cancer, that you're not cured. Do you think today we're at the stage where we can actually be cured, at least from some cancers, specifically with children in any capacity or even in general?
Of course. When I'm speaking about survival of 80 to 85% in children, we're speaking about overall survival. We're not speaking about a remission. Unfortunately, in some areas in pediatric oncology, we're still experiencing relapses, which means the cancer recurs after months or years. Usually after a few years, there's no risk of recurrence. Usually the line was set as 5 years, but sometimes we have late relapses. But cancer is the main point is the cancer is curable in children. It's curable. And when we're not speaking about remission, when we're sitting with parents in maybe the hardest day of their life, they're always asking about percentage, about chances. And we always tell them, your child is not a statistic. Your child, we're going to try to cure him or her. And we're not speaking about temporary cure. We're speaking about him or her being an adult with normal life. And this is another issue, the late effect. The late effect issue of the chemotherapy, and in previous years we used more radiotherapy. Today we use it less and less. The issue of late effect is getting more and more, and I'm happy to say we emphasize more on that issue And we at Hadassah are establishing these days a survivorship clinic. We're following all the cancer survivors in this department as what we call a one-stop shop. They will have nutritionists, they will have, of course, a physician, a social worker, psychologist, physiotherapist, occupational therapist. We will have them all in one spot, because we acknowledge these days that it's not enough to just cure the child. He needs to have normal life. He needs to go to the yeshiva or the university, or getting married and children, and doing all the physical tasks that an adult should be able to do. And this survivorship clinic will be hopefully tackling this main issue that we're dealing with, because it's not enough just to say, hey, goodbye, you're cured. We need to take care of these children, adolescents, young adults in the years after they recovered.
In general, do you find that children who do have a full recovery are able to lead normal lives, have their own children, and carry on like they should be able to?
The answer is mostly yes, but we should emphasize the mostly, because it's not always like that. When you give chemotherapy, when you're doing surgeries, when you're doing radiotherapy, and even if you do the high-tech, cutting-edge technology like precision medicine and immunotherapy, they all have the potential risks. One of the main issues, especially in Israel, especially in Jerusalem area, is the fertility issue. We take it very seriously. We have very experienced staff at Hadassah from our gynecology department and also urology. We're doing for almost all let's separate it to girls and boys. If a girl comes with cancer, we try to estimate the chances that the treatment that we are planning for her will harm her fertility ability in the future. If we think there's the risk is high, we do not the gynecology surgeon. They do what we call oophorectomy. They take out the ovary and they freeze it in slices in case sometimes she will not be able to have children, and then they return it if she will not be able to have children when she's an adult woman. And already many cases of children who were born throughout the world, and also at Hadassah, that were born in that way. Of course, it's invasive, and we have to consider where it depends. There are many factors: how old is the child, how big is the risk for infertility, and how fast we should try start the oncology treatment. Sometimes we don't have enough time. But this is and we also do it for boys. Of course, boys who are over pubertal aged are able to freeze sperm, but even pre-pubertal little boys, we do it. Our urologist team, they do a very special operation that are resecting a very small part of the testicle, and as they do in ovaries, they freeze it and they try to get sperms from it. If when the boy is an adult, will not be able to have children.
Amazing. So, let's just conclude with an idea about what we see in the future. 5 years, 10 years from now, how will everything we're talking about today, how will it look different?
Well, hopefully maybe the people who will come after me, hopefully they will have higher rates of overall survival, because we're around 90%, so it's getting near 100. We will use less chemotherapy and more precision medicine medication, more immunotherapy. We will do less anesthesia. We'll do more liquid biopsies. We will be able to look to find cancer when it recurs faster and more accurate with special techniques in the blood, with special samples that we take from the blood. And we will have more emphasis of preventing upfront, preventing the late effects, the heart, the lungs, the ovaries, the testicles. We will be able to have less late effects than we see today. Also, more, and I think, and we will be able also to locate more condition when we have cancer predisposition, and to locate and to identify the cancer before it happens.
To predict the cancer.
Predict it, exactly.
Amazing. Well, thank you so much, Dr. Goldstein, for being with us on the Hadassah podcast today. It has been such a pleasure to speak to you, and I think that all of our listeners have learned a lot as well as I have. So thank you very much.
My pleasure.